Okay, so I wanted to start, first of all, thank you, Dr. Wong. That was a wonderful presentation. We're now all going to be talking about adolescents. So put your puberty hats on and let's morph into the next developmental age group, the one that's most marginalized, in my opinion, or at least one of the marginalized developmental groups. And this talk is about a topic that is not controversial whatsoever. Transition in gender diverse and trans adolescents. So earlier, Dr. Wong, we had asked, I heard someone say, how many people are pediatric providers of any discipline? How many people are pediatric? How many people are not? Okay. This talk is applicable to everybody, okay? If you're wondering in the audience, I only work with adults, I don't need to know about children, I don't need to know about adolescents, I would say that I hope that you can shift your mentality to that it's important to understand what it is we are talking about when it comes to standard of care for children and adolescents, because you have clients who have kids. You have clients who work kids. I mean, so I think that, right? It's really important to understand the differences. So I'm going to move forward. So our learning objectives today in my rather ambitious deck, and I should just maybe say a little bit about who I am. I'm a child and adolescent psychiatrist in Columbus, Ohio at Nationwide Children's Hospital. Specific to WPATH, I'm one of the curriculum co-chairs for GEI and also one of the co-leads for the adolescent chapter, the non-controversial adolescent chapter of the standard of care. And this is actually an important presentation for me personally because it's the first time I'm presenting the work that our chapter has done from our work group for the last 5 years. So you are oh, well, thank you. I hope that you have the same applause at the end. Okay, so we're first going to start by saying we're going to understand the developmental and cultural factors when working with trans and gender diverse adolescents, breaking that down into 3 topics. Then we're going to understand these adolescent-specific factors and incorporate the standard of care 8 into clinical practice with transgender adolescents. And then we have those 3 topics. This is an overview of the practice statements. I'm not here to read every statement to you out loud. I put them on the slides so that you have them for a handout. So the content is heavy, but that doesn't mean that we're going to read them to you. The principles behind the work we did are the following, and I will read these because they're important. Adolescent gender diversity and or trans identity is not pathology. It's not inherently a mental health disorder and is an expected aspect of general human development. Attempts to change or coerce an adolescent towards a preferred gender identity of any sort is, or expression is harmful, and we in the adolescent chapter repudiate their use. A holistic approach that understands the entire adolescent, so gender, but also other factors that are not necessarily gender related, is important in the context of their community, culture, and family, and when discerning gender-related care needs, should they be sought. Recognizing and appreciating unique aspects of adolescent identity development as distinct from the developmental periods both before that you just heard about and after is important when discerning these needs. And then appreciating the gender-affirming care treatments. Anything from reversible to irreversible are individualized decisions. I mean, you may have heard that a few times all morning. So individualized decisions and should not be assumed as desired or necessary automatically in all situations. So understanding the evidence base and its limitations is important. It's also important that we're prioritizing multidisciplinary perspectives when we can, as they are crucial elements to ethically navigating this process as best as possible. So these are the 12 statements, and then 12 is actually broken down into A through F. The first statement talks about the mental health qualifications of someone working with adolescents directly. Again, the standard of care is a very flexible document because we recognize that different locations in different areas, different cultures, different countries have different policies and different levels of access to the different providers and disciplines. So what we're putting forward is more of a gold standard, not necessarily you must do this. But we felt it was important to put forward a gold standard so that we all are striving to achieve what we can in the places that we do lack access. So for an identity development expert who works with families, we think that's very important when working directly with adolescents. And if one doesn't have that training because you simply don't, you didn't have the experience to get that training, trying to get that training or doing our best to learn and read and educate ourselves on working with families and working with young people who are in that stage of development is important. Second, address gender openly. So facilitate an exploration of the gender care needs that a young person needs without any bias. I think that's somewhat obvious at this point. 3, the importance of the comprehensive biopsychosocial assessment. I will get into more details on what that means. 4, promoting acceptance in families, schools, and other environments. We think that it's important to know all the different environments an adolescent is situated in, not simply their home environment, not only with their parents. 5, I'm not sure if this was clear, but conversion therapy is harmful. 6, we had a specific statement for binding and tucking, simply to help providers realize that these are actually important ways of helping young people achieve a sense of comfort as much as they can, particularly in times when they're not accessing other treatments. 7, same thing. Menstrual suppression is also another treatment goal that many young assigned females at birth may benefit from. 8, we felt that it was important to emphasize that an ongoing relationship with young people, considering we're talking about developmentally, they are all moving forward pretty quickly in life. The difference between a 12-year-old and a 14-year-old is pretty immense compared to, say, the difference between a 32-year-old and a 34-year-old, even though it's the same time difference. So as best as you can, staying with that family and seeing the adolescent achieve different milestones helps you assist the family with care decisions. 9, the importance of multidisciplinary care. The more perspectives you have in a field where the evidence is still in a place of it's still evolving, the more ethical you can approach the decisions. That doesn't mean that every location, again, has all the disciplines involved, but again, this is gold standard. 10, informing families and adolescents about the reproductive effects and fertility options. 11 is an interesting one because it's about the involvement of caregivers and parents. That is a big key difference that exists when working with adolescents. Their caregivers need to consent for their treatment. So if we ignore the parents and we pretend that they don't exist, or we try to bring them in just very, concrete ways, or at the very end of after meeting only with the adolescent, if we're not hearing the parent's perspective, we're not getting to a place of harmony, we're unable to move forward with getting those kids' treatment needs met. And I liked Dr. Wong's example. You can't just ignore the fact we signed up for this to deal with challenging family dynamics. And then 12, well, these are what we put forward as necessary indicators that should be thought about and achieved when considering treatments that particularly have irreversible effects. So when using criteria in a particular country, having that criteria met is important, but it's not just about meeting DSM-5 criteria. 6 months of 2 of the following, that's very, that just boils it down. That's more of it's meant to get access, it's meant to help create a classification, but it's not an individualized experience. And I think we can all talk about the challenges of the DSM-5, but it is important that we use it when we need to. B, a sustained identity experience over time. We think that a sustained identity experience means that young persons' desire to make decisions about what their needs are is best informed when they understand themselves over time instead of when something is experienced very recently. What I should also say, though, is that sometimes a young person doesn't express their experience necessarily, but they feel it internally, or they have a narrative or an explanation for what they went through that wasn't obvious to others. That matters too. That's part of the sustained identity experience. So this isn't about you have to live X amount of years, or, oh, you have to have come out, like the clock starts the day that you came out on September 25th. No, it's about like understanding the internal narrative, and that is what is part of that identity experience, and that's important to know. And then mental health concerns, of course, should be addressed as best as possible. I'll walk you through that more. It's not that we have to have a pristine, perfect psychological, I mean, who fits into that category anyway, right? We don't have to have that pristine psychiatric or psychological profile, because that's not necessarily, accurate. But there are aspects of mental health that can place barriers in us and parents understanding what that sustained identity experience is like for the adolescent over time. Reproductive effects, that's a repeat. And then for puberty suppression specifically, it's important that we get to a place of puberty. It's puberty suppression, not puberty prevention, so to speak. So you need to get to that place before you can start. So these are those statements, which are longer and accessible by web as of yesterday. When I landed, I saw the announcement. Woohoo. I can breathe. Adolescent identity development. Okay, so there's differences between children and adolescents. With adolescents, physical changes are starting with puberty. The challenge here is defining adolescence by age is really difficult, because puberty is not something that is experienced at a certain date or a certain age. It can happen different points for different adolescents, as young as age 8 or 9, the start of puberty, to anywhere from up to 13, 14 even, for late bloomers, and then, of course, most people in the middle. Brain development is happening at that same time. Won't get into the whole neuroscience course that I had to take in med school, but brain development is happening at that time. Sexual identity exploration. This is as kids are starting to have understanding of what their own relationship as a human is in relationship to another human in terms of arousal patterns, romance, sexual identity. And that is another aspect that, while distinct from gender identity, can certainly impact how one thinks about their gender care-related needs. Development of abstract reasoning. So when children are going and becoming adults, adolescence is that period where they're starting to be able to appreciate hypothetical situations, gray zones, not black or white thinking, just like little kids, not categorical thinking. So when you have a little kid, as we heard, gender itself, the way society approaches gender, is very much like a little kid, unfortunately. It's very binary. It's very this or that. And a little kid has a harder time appreciating gender as a spectrum, gender as something that might be fluid for someone, the difference even between identity and expression. And so adolescents now are capable more of having that task, appreciating what gender non-binary identity might mean in relation to a gender binary identity. It means more when they understand the concepts, when they assert who they are, than it does if they can't appreciate the concept. Individuation from caregivers, that's starting to happen. Any parents in the room might be able to tell you a little bit more about that. And then increasing maturity and decision-making capacity, that is something that adolescents can begin to understand lifelong implications. They might not have all made decisions that have lifelong implications, but adolescents can appreciate that better than a child. Differing developmental trajectories. So some adolescents have lifelong gender diverse identity since the minute they can walk or talk. And then others suppress the feelings and they intensify when adolescence or puberty happens. And then others, gender dysphoria may be a new experience for them. We don't bring this up to say this experience is more valid, that experience is less valid. But when you're working with families, anybody can tell you that if a parent has experienced their child's gender diverse expression, the longer the parents experience that, the less the parent has a doubt about what it means in the future. And therefore, that's important information for you as clinicians to know when working with that family. Where's the perspective? It's also important to know the difference if the young person has a different experience than what the parent's experience is, and to account for that. We also have evolving sociological characterizations of gender. 10 years ago when we were meeting about these issues, I don't think that we were quite there with gender dimensionality and gender fluidity. And now, and I'm not saying we're there at all, but I think that we all can appreciate these concepts. We all understand that the pronouns are not just this or that. Like, there's a whole range of how people have expressed themselves and their embodiment goals. So the relevance of statement 2, facilitating an exploration and expression of gender openly and respectfully so that no one particular identity is favored. And 5, against the conversion therapy and being against coerced identities. That's the relevance to what we just said, how there's evolving sociological characterizations, there's varied developmental trajectories that people come with, and then these 2 statements are meant for us to account for those different aspects. There are trends that have been happening with adolescent identity development. So in the past, referrals were much more child-based, and the difference between children and adolescents is children are brought to the doctor. They don't really say, I want to go to the gender clinic, please, right? Like they just don't know. Whereas adolescents are the ones that are typically saying, I have this goal, I have this need, I need help, I want help. And I think that as these issues have become more and more common in society, that's why we're seeing adolescents taking the lead, taking an initiative, and that's why they are coming to clinics far more than children are. An interesting observation that is something that is starting to be studied is the sex ratio. And I don't have an explanation for it, but what I can say is in the past, with the children coming to clinics, it was predominantly trans-feminine or gender diverse assigned males at birth that were coming to seek care. At least I should say the parents were bringing them there, and that in and of itself should give a little bit of an answer about the fact that now far more clinics across the United States and the world are seeing young people present who are with the ratio flipped, where it's more assigned females at birth. I could sit here and give you my theory. I'm sure that each one of you has a potential idea or explanation for it. The goal isn't to try to find answers to limit people from getting care. It's to try to help us know, are there patterns that can help us improve the care that we're giving to people, and why does a trend like that happen? Parents are coming to us with this notion because it's also being twisted to deny the existence of a trans identity for young people. And so therefore, for us to just say, oh, that's not happening, doesn't really show that we are in reality. I can say with my clinic, 2/3 of the young people that come in are assigned females at birth. And that's interesting to me. I think that you would expect it would just be 50-50, and that this would be something that people would, of all types, would come equally, but it's not. But that's just the point I want to make. Access, there's been an increase in the number of services out there. Let's hope that number continues to go up and not down. I'd be remiss if I were to say that we are in a rather challenging political time here, not just in the United States, but also around the world. And this access concern about this becoming more of a political issue does significant harm. I guess I'm preaching to the choir, but it does significant harm to all of us. It does harm to the science, because it's limiting people from feeling comfortable sharing their own experience, turning this into politics. And so I won't go on a rant on that, although I probably could. But the access has gone up, and hope it stays that way. And there's also variation in the way care is delivered in different clinics. So some clinics are based purely within a behavioral health department. Some are based within a medical department and rely on behavioral health teams outside of the hospital. Others are based in both. Some have different factors like I mentioned. So what I always find interesting is that the research that comes from the different clinics, you really do have to know the protocol of the clinic in order to contextualize the research, because they have different people coming to them. Often there might be a self-selection process happening. So if one particular clinic has a full multidisciplinary range of services and begins with behavioral health assessment, families that are not necessarily, that are perhaps avoidant of mental health issues, or even perhaps caving to some stigma related to mental health, won't seek that care out. I find that to be unfortunate as a psychiatrist, similar to earlier Dr. Booth's statement about being biased in favor of mental health. Well, I'm with him. But then you have other clinics where some parents who are very fearful, who are nervous, and they want to have a deeper dive and deeper understanding of their adolescents will seek those clinics out. And so then those two types of kids are in different family environments. And so research coming from those different clinics may differ based on the different populations. It's important to know that. We also have diagnostic differences. I've already talked about resource variation, and then cultural differences. We heard just in the previous lecture about just collectivism-based cultures. It's important to know how languages approach gender. Some languages have an overemphasis on gender throughout every tense, like even in like the noun, the verb, the pronoun, everything. So English, believe it or not, you can actually avoid gender in some ways, whereas other languages it's impossible. And then some languages don't have pronouns at all, I believe, like even in Mandarin, I believe. These are the criteria that you saw earlier. I want to say, I'm not going to go too much into it. Again, it's for classification purposes. Global applicability is really important because often throughout the world, internalized transphobia is seen and it's thought of differently. So I gave a lecture, for example, in Japan, and we were talking about the depathologization of trans identities and thinking like, that's an important goal for us. And the trans people in the audience came over after and they were offended because from their perspective, it was taking away the crutch. Like that was their only way to access medical treatment, was to be considered pathology. So they just kind of went with that and are in somehow like that's just their narrative. And we were challenging that narrative, didn't think we were, and it was interesting. So we have to understand how internalized transphobia may be playing a role in how adolescents develop their own sense of self. Of course, intersectionality is important because we need to appreciate how minority stress and certain groups fit into different levels of different levels, and these disparities are, of course, magnified when you do have ethnic and racial minority youth and families. And so to approach all families in the same way without understanding first how gender roles are even handled in their family, you're talking at different speeds and you're not going to be able to connect with the people that you need to. So now I'm going to go through the gender-affirming treatments. They're broken down into these different groups. So anywhere from psychosocial supports, whether that be resources, connecting families with like-minded groups and kids. I know that in Columbus, for example, we have a Kaleidoscope Youth Center. It's a wonderful place that we have our kids form peer connections, legal resources to help them with any discrimination they might be facing or even name change. Then there's psychological support, so individual therapy, family therapy. Then there's physical supports that are not necessarily pharmacologically based, so binding, tucking. Then we have puberty suppression for younger adolescents who are in the beginning parts of puberty. They have their most benefit, and that's the GnRH agonists. And then pharmacological reversible, such as menstrual suppression or even an androgen blocker. These are important supports to consider. Hormone care, of course, and then surgical treatments, of course. So there's many. If we go through each of them, well, and I actually just did, so I'm not going to read all of these to you, but they're relevant. These first two are relevant to practice statement 4, which is we recommend healthcare professionals who work with families They should work with families, schools, and other relevant settings to promote acceptance of gender diverse expressions of behavior and identities of the adolescent. Notice we don't say, work with these settings to promote acceptance of transgender people. We actually think it's broader than that, because by helping promote acceptance of gender diversity as a whole, we believe that that helps all humans, including trans people. It doesn't reinforce the notion of boxes, which is what we're trying to move away from. For the physical non-farm interventions, this would be statement number 6, that we need to help provide health education on chest binding and genital tucking for our patients. We should not shy away from this, and even if you're a mental health professional, I always hear like, oh, well, that's like the pediatrician's job. Really? Like, I think that you can learn about things and you can take aspects of the other disciplines and incorporate them into your practice, because this is about an identity/body disjunction for a lot of people, and you can't just, oh, I only do identity, or, oh, I only do body. No, we have to understand identity and body and the relationship and individualize that. Puberty suppression, in case you've not heard of it, what puberty suppression does is it stops the, it stimulates the pituitary constantly, which then suppresses the gonads to release the estrogen and testosterone. Look at me trying to be an endocrinologist. Can you tell? Thank you. Yeah. Yes, I know a little bit more about the pulsatile secretion of GnRH, which then leads to LH and FSH. The point being, we talk about puberty suppression as reversible, okay? I'm adding an asterisk to it. It might not be a popular asterisk to add. It's reversible if you were to stop it, okay? So that's a hypothetical. How often do people go on to blockers with the intention of just stopping it and seeing what happens, right? So what's challenging is that it does prevent young people, ultimately, who are appropriate to move forward with more irreversible treatments, to prevent them from going through 2 puberties. We all know that 1 puberty is difficult enough, okay? So if you go through 2 puberties, think about how challenging that can be for someone, okay? So that's the benefit of puberty suppression, and one does not develop the incorrect pubertal changes for them, okay? But there's challenges with puberty suppression that we have to acknowledge, and that's why it's reversible asterisk. One cannot be on puberty suppression endlessly. And clinically, I can tell you it's a challenging issue when you start a kid on puberty suppression and then they want to stay on puberty suppression because they don't want to even make decisions about either of the 2 hormones. And then you get to a place where physiologically we need hormones. And was I joking with you in the break about there's no such thing as non-binary osterone? Sadly, the hormones are binary, okay? So because of that, a decision is going to have to be made at this when puberty suppression is over. So I believe, and this is what our chapter reflects, when you are consenting for puberty suppression, you should also be consenting to end puberty suppression at a certain point in time. And that is important because of aspects around brain development and bone development that if you go on puberty suppression into years, into later adolescence without a form of sex hormone, that's a challenge. So there's other challenges, and I see some talks on the schedule in the upcoming meeting, particularly for the trans feminine population. If one suppresses puberty and doesn't allow genital development to take place, certain surgeons have indicated that that can be a challenge if the adolescent ultimately desires gender-affirming surgery, lower surgery when they're older. Now you try having that conversation with a parent of an 11-year-old about their child's future maybe orgasm. And so you can see how complicated this is, and that's why I think when we just say, oh, puberty blockers, it's just reversible, and we just, it's a very non-invasive treatment, I would say it's more invasive than oftentimes like the media makes it out to be or other people. So that's something that we want you to all be aware of. So I already talked about this, but how long can we start puberty suppression? This is where my endocrinology colleagues come into play, because I'm not the one that's monitoring their bones, I'm not monitoring the labs, and it's just important that we involve the multidisciplinary team. There are more recent thought to start puberty blockers in the Tanner 4-5 kids with simultaneously with hormones, or just before starting hormones, which I believe is different. That helps suppress the endogenous sex hormone such that you need lower amounts of the affirmed hormone or the gender affirming care treatment and less side effects to achieve similar effects or better effects, so to speak, for what the adolescent is wanting. There is one big paper, I would say the main paper for puberty suppression evidence comes from the Netherlands. And the paper was published in 2014 in Pediatrics. There's more data that I don't want to ignore. There is certainly more data that's been published since to demonstrate the benefits of puberty suppression, but not as long as this paper. This one followed kids through hormones and then surgery. But there are some challenges with this paper as well. There's challenges with every research study, I should mention. Okay, so I'm not here to tear apart things. I'm not trying to tear it apart. I'm trying to help everyone realize that oftentimes we look at the research and we like the findings, so we say this is a great research paper, and then if we see a paper we don't like, we're like, oh, look at all the problems with that paper. There's benefits and limitations with every research study, and if you are interfacing with skeptical parents and you don't know that, then you are far less, you might be far less effective at working with those parents to seem credible. And that is simply what I'm here for, is to help be a pragmatic voice of reason in a very polarized political environment where people are coming in with all sorts of ideas about how they are interpreting the evidence. The point of me bringing up this study, well, I'll get to the point, but the point is that we can't rely only on like our clinical awareness. It's like clinical awareness and research together, and that group in the Netherlands, those kids went through a very long, comprehensive diagnostic assessment process over many, many months. Many, I have heard, disagree that process, that it's so long and it's many barriers getting kids into care. And you know, whether I agree with that or not is not the point. The point is that the research that talks about the benefits of puberty blockers comes from that model. So we need to know that and can't say that this applies to kids that haven't been through that model yet. There are reversible gender-affirming treatments like androgen blockers, menstrual cycle suppression, and I have found, this is anecdotally, that these types of treatments are very helpful in the beginning to simultaneously help the adolescent feel affirmed. Let's face it, they don't just feel like talking to a psychiatrist who's like, yes, I'll use your pronouns. That's not sufficient, okay? They want something more. So that, but then you have a parent that's like, absolutely no way, no hormones until 18. Like usually if you use your good diplomatic mediation skills, you can get to a place where using something that is more reversible helps everybody move forward, and it like kind of takes the tension away to be able to now to have the serious conversations. Hormone treatment. So historically was provided at age 16 in the previous guidelines, and then the Endocrine Society guidelines actually kept with the 16 minimum age, which they then said, oh, we're going to give you flexibility to go younger with compelling reason. The adolescent standard of care chapter does not have ages in it. This was a big source of should we, shouldn't we. By putting in ages, it actually deflects, we found it was distracting away from the criteria that we put forward. We felt that people were only going to the age, and that defeated the whole purpose of what we're trying to do. That being said, there has to be some general way of approaching this vis-a-vis age, and if you think about it, going down to age 14, for example, as is stipulated in the Endocrine Society guidelines, 14 is still an age when the late bloomer cis kids are starting puberty. So it's not totally developmentally out of the question for an adolescent to be starting puberty at that time. And if the goal, similar to what Dr. Wong said about getting everybody to have similar developmental experiences together, which is what I argue is why we need to continue helping adolescents be able to live their authentic selves and have their embodiment goals met, that puts them on a path to being able to live authentically at an earlier age, but not too early. So we don't have to, it's tricky, but the hope is that if one were to follow the guidelines, naturally there are certain ages that can achieve a degree of appreciation for the long-standing effects of some of these treatments. So that's why age is tricky. This I already said, but I'm emphasizing it again, that the long-term data, the one with the longest term data, came from those from the Amsterdam clinic. Short-term studies are important, though, and they also support the use of gender-affirming medical treatments in adolescents. And regardless of the evidence base, because I said evidence is one part of this, but also there's an ethical human rights component to treating people, right? We don't rely on evidence for every single treatment we do in medicine. So it's just important that we don't dismiss bad evidence only and take good evidence. We have to just look at the whole thing. Ethics, human rights, justice for trans people, what's developmentally informed and developmentally correct, what's trauma informed. So we can use all of these things. For those that say there's no evidence to support moving forward with gender-affirming medical treatments in adolescents, I would point them to this slide. And that's all I'll say about that. You can look at the different studies and make your own analyses of them. Surgery, this one is getting a lot of talk in the media. I would just say these are all the different types of surgeries that trans people may opt to do. They may not opt to do it. Like if an adolescent, not all adolescents want the same thing for their bodies, and that's okay. Typically, surgery for transmasculine young people, chest masculinization, which does not lead to permanent infertility, which is the key sticking point, is the surgery that is most often done in adolescents who can access the care, who meet other criteria, including the maturity level, all the different indicators that I will talk about. There is research that demonstrates benefit in adolescents that comes from Los Angeles, and they developed a chest dysphoria scale, and then they asked questions about regret to those who went through surgery, and found low regret among the 68 surgical kids. There were 68 surgical kids, 68 non-surgical kids, all with chest dysphoria, and it shows benefit. Okay, getting to decision-making and consent. First things first, let's establish trust. So open-ended questions are the best way to go. I'm going really fast through this because I feel all of you probably have a good sense about doing a history. We, of course, want to screen for gender with all kids. Again, this is not about identifying the kids that we think might be gender diverse or they might be trans. No, like the whole goal here is that we have to develop gender literacy and a sense of gender competence in all the kids that we see in order to treat everybody equally, right? There are many a cis kid who probably has a mental health related issue due to a perceived difference in how they should be, how masculine enough they are, how many feminine enough they are, that we ignore those things for the cisgender kids. So we shouldn't, okay? Because that's what creates an environment that allows us to have our trans and gender diverse patients feeling comfortable. And then of course, if as you get more and more aware of what that young person's needs are, even asking the question, I'm going to ask you questions, and here's how I'm going to ask you questions. Tell me if this is too much for you. So the comprehensive biopsychosocial assessment, this is something that many people I have heard feel like this specific recommendation leads to more barriers for adolescents than takes away barriers. And I do understand the history that my own profession as a psychiatrist that we have with the transgender world and transgender community. And it's been an awful one because historically our colleagues made people have to do certain things. And then the minute you say you have to do this or you have to do that, then you're creating an environment where there's not trust and people are inauthentic and they just want to get their needs met, so they do whatever they need to do, right? And the goal here is like, oh, if we create an assessment, how are we going to create an environment that allows young people to feel comfortable? It's not about whether or not we do an assessment, it's about how we do the assessment. It's about demonstrating to families and gaining their trust by showing them that getting to know all the different aspects of who they are helps us help them better. And not helps us tell them what to do, but helps us be able to provide the range of opportunities, the risks, the benefits, and think through these decisions so that they are informed when making through the decisions. In a time like now, we have to be as pragmatic as possible. We cannot just be rushing sort of decision-making with families who aren't ready to do that. The goal of the assessment is not to say you have to go into therapy. It's to say, oh, I think therapy might be beneficial for you. Here's why. Do you want to do it? Do you not want to do it? And if you don't do it, here's what might happen. And if you do it, here's what might happen. Let's take that. Let's go forward that way. Again, the assessment is supposed to provide a gold standard, recognizing that not everybody has access to that. The goal also is to get more information on gender identity development, social development, intersectionality of identities, understanding what mental health and psychiatric or psychological vulnerabilities that young person has. A young person who has trauma or PTSD, it's important that we know that so that we can approach them in a way that creates a comfortable environment for them. That when they are navigating the world and when they are sort of afraid to maybe perhaps live out their experience because of some traumatic event that they went through, that we're not assuming that that aversion to that event is one thing when it's a different thing. Okay, that's what this is about. It's to look for and understand what is it that might be a barrier or also might be a support for the young person. And of course, understanding their decision-making capacity. So question for all of you, can every adolescent appreciate lifelong implications of their decisions? I'm sensing the parents probably are laughing. I would say some can and some can't. Does that matter? I guess so when we're talking about long-standing decisions. How do adolescents differ from adults in their approach to decisions? I talked about how they differ from children, but they certainly differ from the adults. So the statement about maintaining an ongoing relationship throughout the duration of puberty suppression treatment or hormone treatment is based on that notion because cognitive development changes the way adolescents think through things over time. So in the beginning of adolescence, they're still thinking more like a child. And then by the end of adolescence, you know, they have their financial planner ready. And they're just like off to they're off to the real world. But in between, that is such a turbulent set of years that different kids achieve these different ability to appreciate the hypothetical situations and understand the middle, that we need to know where they're at when they're making these decisions. It also helps us sit down and make a reanalysis of the risk-benefit for each treatment. So when an adolescent is going on to puberty suppression, they are a very different human when they are making decisions about hormone treatment or later surgical treatment, if they choose those. To say that the person we met when they were 10 and apply that logic to the recommendations we make when they're 14, that's inappropriate for us. We need to do a reanalysis with the family. And some young people, their needs change over time. A lot of young people, depending on where they're at, they're caving to the notion of the binary gender. And when we even educate them that there's multiple ways that that one's identity can be expressed, and then they're surprised. They're like, oh, really? Because some people just come from towns that may be rural. They might not be as connected. We just can't assume that every adolescent comes from that, like, hooked in social media urban center. And this also helps protect their individual identity development over time. It gives them the space for it to be adolescent-led and not society-led, not parent-led, not me-led. It's about protecting their ability to know who they are on their own. The statement 10, helping understand the reproductive effects and understanding the loss of fertility and options to preserve fertility. Well, to what degree is a conversation important to have? How many people have heard the adolescent say, I don't want to talk about that, I'll just adopt, I know. We've all heard them, like that's said over and over. What I would say is it's important for us not to put our ideas about what should or shouldn't be when it comes to reproductive health conversations into play. But an adolescent who says, I'm just going to adopt, leave me alone, is different than an adolescent who says, I don't really care about this right now, but I realize I'm a teenager. Maybe when I'm older, I could change my mind, but I don't think I will. That second group shows that that adolescent is capable of understanding that they don't know what their life may be like. That's the type of young person that understands that their decisions that they're making now are impacting them and they could be appropriate for their future or they might not be. And it's not up to us to say, well, if your thing is going to change in time, if your priorities change in time, well, then we shouldn't do this. No, it's to say, great, you understand that. Now let's move forward with what you feel you need. In the first kid, it seems like we may want to have a session to help them appreciate that their 30-year-old self is very different than their 14-year-old self. And even for young people that understand that some other people have evolving needs, and they don't think it applies to them, that's good, that's helpful, that's what we are aiming for, is to help adolescents appreciate that. So then practice statement 11 is about the involvement of parents. I think this is more of a legal issue than it is anything else, but if you go forward with, say, one parent consenting and then you have a lawsuit on your hands from the other parent, you're not necessarily helping that adolescent out. So that doesn't mean that we should involve a parent who's not been in the adolescent's life for 10 years and estranged from the family. Oh, wait, we need that second parent to get their consent. That would be an example of something that's determined to be unnecessary, or say a parent that's been traumatic or has physically abused their child to have to engage that parent into this decision making. That's harmful to the adolescent. So in scenarios where it's harmful or unnecessary, of course, that is not helpful to the adolescent. But as best as possible to have consensus that protects the adolescent and protects that decision for the long haul. I already acknowledged some of this. Same thing also with young people who may be in the foster care system, which I find actually are really challenging because some of the agencies have these blanket rules about I'm not starting until 18, and it involves a lot of advocacy work that our team has to do with those agencies, but it's important to do them. Kind of a risk of not putting ages in is that it enables agencies to sort of make their own rules up, or insurance companies to make their own rules up about things, and usually those are not the rules that we want. So as far as decision-making capacity goes, 12A through D, 1 is meeting the criteria, B is that long sustained experience over time, C is the cognitive and emotional maturity, and D is that mental health issues are addressed. Okay, I already said this. So co-occurring mental health entities, this is the final section of my talk. I'll try to get through it. Back to statement 3 about the psychosocial assessment and statement 12, which is 12D, which is about the mental health issues. We need understanding and clarity of the mental health diagnoses to optimize treatment, okay? Again, did I say that we need to treat everything in order to get to a place to require that for moving forward with irreversible decisions? No, we're talking about what's optimal, what might not be optimal, and then taking it from there. We need an understanding of their individual psychological factors to optimize treatment. This is kind of how the adolescent interacts with the world. So I would say there are some young people who are highly anxious, highly afraid, highly resistant to change. They themselves are saying, I'm going to defer, I'm going to defer, I'm going to defer. And I might actually think that they would do better if we moved quicker, okay? And I'm using this as an example to say my agenda is authenticity, not a gender, okay? It's authenticity. And the longer they delay their authenticity, the more challenges they have. It's not up to me to say we need to transition now, though, right? That is a very individual, family-based decision. Just understanding what are the factors involved that determines the adolescent's pace of treatment, and what are the factors that we see that can affect the pace, and are those aligned, and if not, why not? Oh. It's important to understand the relationship between the gender and any co-occurring mental health concerns, because sometimes there's co-occurring mental health concerns that are not related to gender. And I'm going to talk about that for just a quick second. So we're seeing more and more heterogeneous groups of kids seeking care. And they differ in their emotional maturity, they differ in how they express gender, and they differ from their psychological or psychiatric vulnerabilities. So the main questions to ask about each of these three are, how emotionally mature is the young person for their age in terms of their decision-making capacity? To what degree does the sought treatments address their core gender identity? And by core gender identity, I mean a gender that is internally true for that person. And then third, what's the relationship between the gender issues and the mental health related clinical presentations? So here's a question. This first question is one that is certainly not something I hear a lot of people ask, because it can seem like I'm not affirming of everybody, but I'm not here to try to make everybody happy. I'm here to be real. Does gender serve the same identity-based function for all adolescents? And I would say no. I would say that gender does not serve an identity function for every young person that comes through, okay? That's not a comment on whether or not trans people should exist. That's a comment on adolescent identity development. That's the reality of it. And if we assume that gender plays an identity function for every single kid that comes through the door and work towards achieving that harmony for them, then we are missing the mark. And we're actually not respecting the full diversity of the gendered experience by making that assumption and reducing everything to gender. And so it's somewhat of a controversial thing to say, but, and I'm ready for tomatoes to be thrown at me if there's a disagreement on that. And again, I can't emphasize enough that the goal is not about like questioning whether someone is trans or not trans. It's understanding the function with which gender plays for that person. And I also would say that I question certain cis people who say they're cis when they're not. So it's not just about like trying to make people cis, right? Like, that's not the agenda here. The agenda is authenticity. So what about now the mental health? So understanding the relationship between the higher acute kids, so kids who are like planning out suicidal, ways and methods to end their life, like those kids, we need to understand what's the source of that, how many other things are contributing to that issue, gender experiences included, and some of the other issues. We have to understand the whole picture so that we can truly know what to do to intervene. So when it comes to the presence of co-occurring mental health conditions, if they exist at all, and I should say, we see so many young people without any major mental health challenges, and I don't assume every kid has a challenge. As a psychiatrist, I tend to see the more challenging ones, but we have to look at what are the mental health experiences that arise from gender dysphoria, because then you address gender dysphoria. What are the mental health experiences that arise from the stigma of gender diversity? What are those that are distinct from gender dysphoria and stigma? Are there any mental health experiences that should be prioritized first to help, perhaps, I'll give a good clinical example, like parents who think that a mental health issue is impacting the clarity of that experience for them? I am far more likely to get that kid their gender care needs met if the parents see that we've addressed something else first when it needs to be addressed first, simultaneously supporting them socially, psychologically, even through menstrual suppression or androgen suppression. So those types of things can really help us. And then, of course, there are mental health experiences that impact identity development. So there's more, but I'm just trying to get you to all understand adolescents are complex. Welcome to adolescence. Specific, we always need to call out for the autism spectrum kids. I know that I'm probably approaching the end of my time right now, or have I passed it?
We have some elasticity in the question period. So.
I'm pretty much done, but okay. So basically, autism, there is data that is out there that does come from the Amsterdam clinic. I always point to them because they were one of the first in the world and the most academic to provide us with research and data, uninfluenced by politics, I think, so that's also helpful. And we don't believe that autism or a neurodiverse presentation or experience should prevent someone from transitioning, but I need to understand how to be neurodiverse friendly to them and speak in ways that they can understand, and that's really important to help them process their own goals. Ways I spoke today in this lecture might not be neurodiverse friendly. Like I might have just gone off the cuff or said things that are not easy to hear. So you have to be cognizant of the fact that we're not always creating an environment that's helpful for everybody. And the additional considerations for that overlapping group is that, specific needs about transition. By definition, transitions are challenging for some neurodiverse people, so that's something that we need to help with. They may be more categorical or concrete. Social cues are important when it comes to helping that young person detect safety in their environment. We don't want them to not know and sense when a particular situation is unhelpful or unsafe for them. Multidisciplinary care, just to get really through this. Let's see. Yes, I'm very end of my talk. Basically, I think I already alluded to the fact that with adolescents, we have evolving data, not the same data that we have with the adults. We have parents that have to all be in agreement. We have identity development. These are aspects that make adolescents differ from adults. This is why having more disciplines when possible helps move forward with decisions. It's also, I'm challenged sometimes by my colleagues who they may think that I'm off on something, or I may think they're off on something, and that helps us think better, and it helps us help the adolescent better. So take-home points. I'll read these to you. It's 2 slides. It's important to understand the unique aspects of adolescent identity development and family dynamics when working with these kids. coercion is bad. Adolescents by nature are going from childhood to adulthood, and they're going through many different domains of development: physical, emotional, cognitive, psychological, identity, social. Thus, appreciating how they align or not align is important when working with adolescents and families. Understanding the psychological and possible psychiatric needs of the person, as one would do with any adolescent seeking treatment, is important. And one thing I will mention about the mental health thing, to add to Dr. Booth's excellent talk earlier, it's good for us to think about how important gender-affirming care is for the mental health of young people long-term, but we can't always overemphasize how much better people do when they move forward with their gender-affirming care transition needs, because that puts a lot of pressure on that person to have to be perfect or not have mental health concerns. So if we actually give I always say to my patients, now that we're starting testosterone or estrogen, now you can finally have mental health problems, right? And it's really important, because then parents don't approach the kids saying, how come you're having mental health problems? We thought that the testosterone was going to be the answer, right? So I think it's important that we don't only produce the narrative of hormone surgery blockers lead to automatic life improvement for everybody, because people are people and we're all entitled to our mental health problems. And then understanding the needs of those people, is really important. And then how different systems approach gender identity and expression is important, and facilitating acceptance through all points of their systems are important. In order to do this, in order to know how informed an adolescent can be, we need to be informed about who they are. So therefore, a needs discerning assessment, which again is not saying you have to do therapy. That is what we're describing as gold standard. Understanding the different factors impacting adolescent decision-making. Understanding that the evidence base for treatment, the long-term evidence base for treatment, comes from a group of kids that went through a solid, long assessment process. And then multidisciplinary perspectives provides the most comprehensive support for treatment needs, particularly for decisions with significant lifelong implications. I think that brings me to the end, and that brings us to our panel.